Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Perfect. Thanks so much, Brian, and welcome to all the ECHO participants. I'm really excited to be able to share with folks the updates on HIV co-infections and comorbidities from this year's virtual CROI. So I will just dive right in. These are my disclosures. So the leading player in co-infections and comorbidities in CROI this year, not a surprise to anyone, I'm sure, is COVID-19. And there was a ton of great science about COVID-19. I'm going to focus specifically on a few studies that looked at specifically the interaction between HIV and COVID-19 in primarily people in the US. So I'm going to talk about two studies that looked at people with COVID and compared people with and without HIV, and then a few updates on people with HIV with and without COVID to try to tease out some of the interactions and what we're seeing across the country and across the world. So Dr. Lee from the UK presented a fantastic study that he and his group did looking at a cohort of hospitalized people with COVID-19 in the UK and compared people with HIV and a matched group of people without HIV. So this is all hospitalized patients and was looking at the outcome of time to improvement in their COVID-19 disease or discharge from the hospital. So this was looking at a population who were hospitalized in the UK between February and May of 2020, 68 people living with HIV, and a matched group of people without HIV, 181 of those folks who were matched based on when they were diagnosed with COVID based on PCR, matched based on hospital site and gender and a 5-year age band. So what did they find? They found that in this cohort, people with HIV were more likely to have certain comorbidities, including CKD, end-stage renal disease, liver disease, but were less likely to have rheumatologic disease than people without HIV. Overall, their main result was that they found that people living with HIV had a longer time to improvement or discharge from the hospital, so did worse than people without HIV. And that was a hazard ratio of 0.57 that was highly significant. But then when they adjusted for the comorbidity burden, as well as age and race ethnicity, the difference decreased and was no longer significant. So comparing people with HIV still had a longer time to improvement and discharge, but not as much longer and no longer statistically significant. There was no difference in mortality seen between people with and without HIV and COVID-19. So their conclusion was that in the UK, among people hospitalized with COVID-19, people living with HIV did not have significantly different outcomes compared to people without HIV after adjusting for other comorbidities. A similar study done in the US looked at a massive national cohort of people who had PCR positive COVID who were identified between January of 2020 and up to February 2021. So a year's data of people with COVID in the US. And this is the National COVID Cohort Collaborative looking at routinely collected medical record data from 39 centers across the US. And the investigators in this group looked again at all people with COVID, not all hospitalized, so some were and some were not hospitalized, and compared people with immune suppression in two different categories. We're going to focus on the HIV immune suppression. So they looked at two main outcomes for people with COVID. They looked to see the odds of hospitalization, indicating more severe COVID, and looked at odds of needing to be mechanically ventilated if they were hospitalized. And again, they were comparing people with HIV to people without HIV. So in the first table on the top, this is looking at the odds of needing hospitalization for COVID in people with HIV compared to people without HIV. Looking just at HIV status, the crude estimate showed more than a twofold increased odds of hospitalization for people with HIV compared to people without HIV. When that was adjusted for age and race, that increased odds attenuated a little bit to 1.63, and then attenuated even further in the third adjusted estimates, odds ratio of 1.32 when the comorbidity burden, again, was adjusted for. So after all adjustment, HIV status alone was still associated with an increased risk of hospitalization that was very significant for COVID, but not as much as before adjustment. Then looking at very severe COVID, so COVID so severe requiring intubation and mechanical ventilation. In the bottom table, you see that comparing people with HIV to people without HIV, about almost a twofold increase odds of requiring intubation for people with HIV that attenuated slightly with adjustment, but not much, still about twofold increased need of intubation for people with HIV. So overall conclusion that people with HIV did have more severe COVID disease than people without HIV, even after adjustment for comorbidity burden. So those were two large abstracts, very large national cohorts that were evaluated. I'm going to do a lightning round for each co-infection as well, where I give kind of key takeaways from a few other abstracts presented. So Dr. Yandewa at CASE presented an abstract looking at another large database of people with COVID cases, comparing, again, people with HIV to people without HIV. And in this cohort, they found that people with HIV, again, had higher odds of hospitalization, odds ratio of 1.26, and had increased odds of needing ICU care or mechanical ventilation, 1.32, compared to people living without HIV. But HIV and no HIV had comparable mortality at 30 days. So similar, consistent results to what was seen in the national cohort that was just presented by Dr. Sun. And then two abstracts that looked at populations of people living with HIV and compared COVID to no COVID. So a group in Atlanta looked at 180 adults with HIV and found that the risk of hospitalization for their COVID increased with each increasing comorbidity. So comorbidities looked at were things like diabetes, hypertension, obesity, and they weren't looking specifically at the risk of each specific comorbidity, but the total number of comorbidities, and found a steady increase of odds for hospitalization among people with HIV. And then we looked at the CNIX cohort of people living with HIV, 6 sites throughout the US, almost 16,000 people with HIV, and looked at who in this cohort got COVID over the past year from March to December of 2020. We saw that there was a disproportionate number of COVID cases in Black and Hispanic people with HIV, and that being female, having diabetes, and having an elevated BMI was associated with having COVID-19 among people with HIV. Interestingly, there were no HIV-specific risk factors, CD4 count, viral load status, that were associated with having COVID-19. But then when we looked at who among people with HIV who got COVID-19, what were the risk factors for more severe disease indicated by hospitalization? We saw that older age, cardiovascular morbidities, diabetes, kidney disease, Hep C, and in this case significantly, a low CD4 count were all associated with a strongly elevated risk of hospitalization. So again, among people with HIV, certainly immune suppression with low CD4 count is associated with worse COVID-19 disease, as well as what is consistent with what's seen in the population of people without HIV, cardiovascular morbidity associated with increased risk of hospitalization. All right, switching to another largely respiratory infection, there was some great research presented on HIV and TB co-infection at CROI this year. One of the most significant studies was a study presented by Dr. Pettit from Vanderbilt looking at 3 different TB treatment regimens for people with HIV using rifapentine instead of rifampin to try to shorten the duration of TB treatment. So this was a 3-armed study that was conducted in multiple countries comparing standard 6-month TB treatment in this top bar with 2 experimental TB treatment regimens. One shortened, and the only substitution was rifapentine instead of rifampicin. And then the regimen at the bottom was a shortened 4-month regimen substituting rifapentine and moxifloxacin for rifampin and ethambutol. And so this group looked at the primary endpoint, which was TB-free survival at 12 months after randomization to one of these 3 arms. This is designed as a non-inferiority study with a margin of 6.6%. So this figure shows the entire population of people who were screened and randomized. The study included people with and without HIV, but I'm going to focus on the population of people with HIV who were randomized to each of the control arms, so 71, 71, and 72 in the control and intervention arms. Importantly, for people with HIV, inclusion criteria included having a CD4 count above 100 and either being on ART already with an efavirenz-based regimen or would be starting an efavirenz-based regimen within 8 weeks of starting TB treatment. And for people who are already on ART, they were required to have a viral load less than 200. So main results, what did they find? So the top set of graphs and the figure shows the outcome, TB-free survival at 12 months, comparing the rifapentine arm to the control arm. And what we see in this forest plot is that the effect did not meet the non-inferiority threshold. The overall estimate for people with HIV favored the control, so standard 6-month TB treatment. If we look at the graph for the second intervention arm, the shortened regimen using rifapentine and moxifloxacin, the estimate for people with HIV strongly favors the control, so a much improved TB-free survival, and it was well within the non-inferiority margin. So conclusion here is that a shortened TB treatment regimen with 4 months of rifapentine and moxifloxacin is non-inferior to standard 6-month TB treatment for people living with HIV. And this has big implications for shortening TB treatment for TB, which still remains globally the leading cause of death among people with HIV. 3 lightning round slides for TB. One study from Uganda looking at TB meningitis in people with HIV. So this study looked at increased dose rifampin to treat TB meningitis in people with HIV and found that the majority of people enrolled were HIV positive with a median CD4 of 50. And this was a phase 2 study looking at safety and dosing. It wasn't powered for clinical endpoints, but what they did find importantly was that with the standard dose of TB treatment, fewer than 50% of patients achieved detectable levels of rifampin in the CSF compared to over 94% having detectable rifampin levels in CSF in both of the increased dose rifampin arms. And no excess toxicity was seen with high dose rifampin in the 2 arms with high dose IV and high dose oral rifampin in the 2 arms. So I think this is a big push to have us be more aggressive with our rifampin dosing for TB meningitis, with the next step being clinical endpoints to see if we can improve mortality. As a really kind of interesting teaser study from Taiwan looked at treating latent TB in people with HIV who were taking Biktarvy using the super short regimen for latent TB treatment of 1 month of isoniazid and rifapentine. And previously, Biktarvy had not been recommended to be used with rifampin or rifapentine at all because it did not achieve adequate therapeutic levels in the initial PK studies. So this was a little bit of a bold move to attempt this. So in this population of 50 participants who were all on Biktarvy, all were virally suppressed at the time they started their latent TB treatment, 16 did experience viral rebound during the 1 month they were taking their latent TB treatment. All of them resuppressed at 3 and 6 months post the end of their latent TB treatment. So I think this raises the question of what's the right thing to do here. We now have many people who are on Biktarvy as their primary regimen. For people who want latent TB treatment, 1 month of latent TB treatment is certainly more appealing than 3 to 6 months that we might otherwise offer. But 16 out of 50 did experience viral rebound with that combination treatment. So I think raises a lot more questions than it answers, but interesting to see. And then another really important study, sub-analysis given by Amita Gupta out of the IMPACT study, looking at pregnant women with HIV who were receiving isoniazid preventive therapy for TB prevention as well. They found in this massive study that was comparing 9 months of isoniazid to 3 months of isoniazid and rifapentine, looking at the women who received 9 months of isoniazid, there were 128 women who had known pregnancy outcomes during the study. And what they saw was that there was an increased risk of negative birth outcomes, including non-live birth and other adverse pregnancy outcomes, with an elevated risk ratio of 1.92 among women who had INH exposed first trimesters. So I think this adds to the growing body of evidence that there is a potentially small but quite real negative effect of isoniazid in early pregnancy. And certainly is going to make me rethink how we advise women to take TB preventive therapy in early pregnancy. The last study I want to talk about, and I know I'm running the end of time, but I really want to cover Hep C because that's a critical co-infection that we deal with a lot of our treatment. And this was a fantastic study that Sunil Solomon from Johns Hopkins did, again, a multi-site international study that very conveniently lent itself to the COVID era where it's harder to see patients, it's harder to have people come into clinic. And so their question was, can we take a pretty high-intensive treatment program for treating Hep C, which normally requires a lot of baseline labs and frequent visits and treatment monitoring, and can we get rid of all of the high-touch intervention and give a really minimally intervention Hep C treatment regimen? So they enrolled about 300 people, almost 42% of whom had HIV, and there was no baseline lab testing. Basically, there were 2 visits to treat the Hep C with Epclusa. So patients would be seen at week 0, they'd be given their entire treatment course, no labs, and then they would come back at 24 weeks to have a final measurement of do they succeed in achieving sustained virologic response. There were 2 phone check-ins, one at 4 weeks and one at 22 weeks, just to check in, but there were no scheduled other clinic visits or contact points during that time. So again, 300 people enrolled, about half of whom had HIV. For people with HIV in the study, they were required for eligibility to have a viral load under 400, but otherwise a pretty typical distribution of what you would see of people with Hep C and HIV co-infection. And this was the overall conclusion of who achieved sustained virologic response. This vertical line here is the 95% rate of sustained virologic response. And I think you can see from the pretty tight distribution around here that it was pretty close to 95% sustained virologic response in the entire population across most variables. The only population that had a significant deviation, had lower rates of sustained virologic response, is the age band of 20 to 29-year-olds. There were 20 non-responders overall. 34% of them did report incomplete adherence to their treatment. And importantly, they also found that there were very few severe adverse events reported, that it was safe. So conclusion was multi-month dispensing, minimal interaction Hep C treatment is safe and effective for treatment-naive persons who do not have decompensated cirrhosis. The one line each for a Hep C lightning round is self-testing for Hep C. So moving from the HIV self-testing to Hep C self-testing was very acceptable, and with some training, what did seem to be pretty effective among a multi-country study of people using an oral swab Hep C test. So that's another armament tool. And a modeling study looked at the most cost-effective strategy for Hep C testing to try to eliminate Hep C in MSM in the US. And their model suggested that a 6-month frequency testing for MSM with HIV, annual testing of Hep C for MSM who are using PrEP, and any time that HIV was tested for non-PrEP using MSM would be the most cost-effective approach that would still achieve Hep C elimination by 2030 for the goals. All right, that was a whirlwind tour of co-infections, and thank you very much for your attention. Happy to take any questions.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.